Great. Well, good morning, everyone. Thank you for joining us on this Friday morning. It is my pleasure to introduce Dr. Laramie Smith today. We're very lucky to have her. She's an associate professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego in the School of Medicine. As a social psychologist, her community-engaged research applies social and behavioral theory from a public health perspective to examine individual and socio-structural contexts such as stigma, substance use, social networks implicated in improving health equity among people living with HIV and substance-involved communities. She is skilled in qualitative and quantitative formative research methods and in the development, implementation, and rigorous evaluation of HIV prevention and treatment interventions in clinic and community settings. Across this work, Dr. Smith maintains an intersectional focus on gender, ethnic, racial, sexual, substance use, and recovery identities, and the mechanisms through which related sociostructural factors manifest to undermine engagement in HIV and substance use prevention and treatment services. We're very much looking forward to hearing your presentation, Laramie, especially in these interesting times that we're living. So please take it away.
Oh, thank you so much. It's very, very formal, but appreciated. Let's see. I just need to share my screen to get started with that technicality. I think it is this one. And then I'm going to launch and tell me if you're seeing the slides, not the presenter view. Perfect. Okay. So then just a note. First, I want to start by thanking you all so much for the opportunity to present this work at High Rounds. Thanks to Jill for her persistence in getting me here, and a huge thanks to Marvin for really making this process so seamless. It's really an honor to join you at 8 a.m. on a Friday. Some of my favorite people, even if it's not my favorite time, but still very happy to be here. Just a technical note, though, I can't see anyone if your hand is raised or if you put questions in the chat while I'm in presenter mode, the way that my computer's set up. So please feel free just to unmute, ask any clarifying questions, and know that I anticipate we will have around 10 to 15 minutes at the end of the talk for a robust discussion at the end. So I also want to start by thanking all of our HIV Prevention Trials Network, or HPTN 094 participants, the local communities, study staff, and providers who really made this work possible. In addition to my co-authors, I'd also like to thank Dr. Dale Berwin, who was our medical officer, and Phil Andrews at FHI 360, who reviewed the implementation, evaluation, study design, and protocol extensively and provided in-depth feedback on the manuscript, whose results I'll be presenting now. I want to extend a big thank you to my IS mentors and champions, Nicole Statnick and Borska Rabin here at UCSD, as well as the study co-PIs, Steve Shoptaw and Nabila El-Basil, and Verdana Chandler at NIDA, who saw the importance of integrating an implementation science evaluation component into the 094 protocol from the very beginning. And this is the first HPTN-funded protocol to have a formal IS evaluation. So to kind of help orient us to today's talk, first, I just aim to provide a very brief background overview of the implementation science framework and methods that we used, and then dive into the results, really talking about the pre-implementation neighborhood selection process, the characteristics of the neighborhoods where the intervention was implemented, and the factors that affected, the viability of certain neighborhoods to be able to deliver the intervention. And then we'll have time for discussion. So just by way of brief background, there are approximately 3.7 million people who inject drugs in the US, who disproportionately account for 7% of all new HIV diagnoses annually. Increased fentanyl, a highly potent opioid in the US drug supply, has accelerated both HIV and overdose risks among people who inject drugs, with over 100,000 fatal overdoses reported in recent years. There are highly effective evidence-based interventions to prevent HIV transmission and mitigate overdose and HIV-related harms among people who inject drugs. Those are ART, or antiretrovirals, PrEP, pre-exposure prophylaxis, both of which can effectively stop onward HIV transmission when taken continuously, as well as medications for opioid use disorder, or MOUD, including both methadone and buprenorphine, which are gold standard treatments for opioid use disorder, reducing both overdose and HIV-related harms. But the uptake of these evidence-based interventions is just strikingly low. In line with international guidelines, there are recommendations that these evidence-based interventions, PrEP, ART, and MOUD, be delivered in integrated care models. However, despite the availability of these highly effective evidence-based interventions here in the US, the domestic HIV burden among people who inject drugs is really driven by this interconnected syndemic factors, including limited access to healthcare and MOUD, poverty, polysubstance use, and unmet mental health needs. The health impacts of these interconnected syndemic factors are just further amplified by the criminalizations of drugs, of people who use them, and of stigma towards people who inject drugs within the healthcare systems, which contribute to the disruption and discontinuation of healthcare services, including limited access to HIV-related medications and MOUD, really kind of hindering treatment adherence and retention. So, in response, HPTN 094 was designed to use a complex intervention design called INTEGRA to address these syndemic barriers. INTEGRA delivers integrated HIV, PrEP, and MOUD care through mobile units in local neighborhoods with peer navigation support to improve treatment initiation and retention among people who inject drugs. And increasingly, implementation science is being used to aid in the planning and successful delivery of complex evidence-based interventions and their adoptions among people who inject drugs in the US and abroad. Prior MOUD and harm reduction research has examined implementation facilitators and barriers at the organizational healthcare and social service systems. They've looked at workforce capacity, financing, and policy contexts. And in the context of HIV and substance use specifically, implementation frameworks and methods have been leveraged in the US to articulate organization and patient perspectives of harm reduction interventions for people who inject drugs with HIV, and to help expand harm reduction interventions through different modes of delivery, such as pharmacy services directed to people who inject drugs. But to date, fewer studies have looked, kind of outside of those organizational or inner context framing to look at how to use implementation science methods and frameworks to understand the outer context, or, for example, the community environments and how those can influence HIV and MOUD service implementation. And so we worked to set up HPTN 094 using a hybrid type 1 effectiveness implementation study design, where our primary focus is to determine the effectiveness of INTEGRA in reaching eligible people who inject drugs in local communities, who are then randomized to the integrated care arm delivered on the mobile unit with peer navigation support for 26 weeks, compared to a peer navigation only arm that supported linkages to existing HIV and MOUD services in the community for 26 weeks. At week 26, facilitated access to these evidence-based interventions and ended, but participants were still followed through week 52. And the reason for having an active comparison arm is an important point to raise here, because there's no real standard of care condition for people who inject drugs, given the syndemic-related barriers to even accessing care that were previously reviewed. So the standard of care arm, it's 8 a.m., apologies, would essentially just be like reinforcing the no access to healthcare services, which for half of the participants, and that was just deemed unethical by all research and community partners. And so we had an active peer navigation arm for comparison. Second, our focus in this hybrid design was to focus on and prospectively characterize INTEGRA implementation facilitators and barriers kind of across our 5 study sites, as well as identifying unique factors within our 5 study sites, which were located in New York, Philadelphia, DC, Houston, and Los Angeles. This randomized controlled trial aims to evaluate primarily the effectiveness of INTEGRA on 2 primary clinical outcomes: greater retention in MOUD at week 26 in the integrated arm compared to the peer navigation arm, and increased retention on ART and PrEP at week 26 in the integrated care arm versus the navigation only arm. But our multi-phase implementation evaluation used an embedded mixed method study design in order to inform where we would deliver the INTEGRA intervention in the pre-implementation phase, to guide and optimize the real-time delivery of INTEGRA during the implementation phase, which has been completed now, and then to understand how the local implementation context might actually affect INTEGRA outcomes and inform how INTEGRA could be implemented in similar public health and community settings in the evaluation phase. So our IS evaluation was guided by the Practical, Robust Implementation and Sustainability Model, or PRISM, which many of you may be familiar with at this point. And it's a multi-level framework that aims to move research findings towards healthcare practice. And it does this across 4 theoretical domains. And so I articulated HPTN 094 to these theoretical domains. The first being looking at the patient and providers' perceptions of INTEGRA's evidence-based interventions. So what did people who inject drugs and the mobile staff, mobile unit staff, think about the perceived need for or effectiveness of buprenorphine for MOUD and ART and PrEP? We also aim to capture the characteristics of people who inject drugs and mobile unit staff, and how those characteristics, such as knowledge, efficacy, and goals, affected the delivery of integrated care or the ability to access integrated care. Third, we examine factors in the external community environment and how those can influence how integrated care was delivered by the mobile unit staff and accessed by people who inject drugs. And fourth, we examine system-level factors and infrastructure that's needed to that's needed to affect the delivery of integrated care, or may be affected by the delivery of integrated care in a mobile unit. So, like, what are the resources? How do you bridge relationships, between INTEGRA, peer navigation staff, and other community services? What kind of space is needed? Those types of things. And we further assess the linkages between these PRISM determinants and local healthcare and public health systems, as well as the potential impact of the COVID-19 pandemic, which was very much happening during the development of this protocol and implementation of INTEGRA. So we developed this process to prospectively examine the role these determinants had on implementation outcomes when conducting the randomized control trial. For example, determining the appropriateness or the viability of local implementation neighborhoods, and on subsequent observed clinical outcomes among people who inject drugs following the conclusion of the RCT evaluation, such as on the adoption and maintenance of ART and PrEP and MOUD treatment at week 26 post-baseline. So this particular analysis, and for the rest of the talk, what we're going to be focusing in on is identified in Path A in this figure, that specifically draws on multiple data sources to account for how contextual factors in the community environment, things such as, social factors, physical or built environmental factors, drug use landscape, sociopolitical landscape, how those contextual factors in the community environment affected the viability of delivering INTEGRA in local neighborhoods. And so how we did this is that our overall implementation science evaluation leveraged 6 different data sources. And across these 6 different data sources, our data were processed, coded as needed, and integrated on monthly calls in order to first document the implementation facilitators and barriers that we were observing. Second, to make data-driven decisions about how to reach the target population. And 3, to inform, document, and classify any adaptations that needed to be made in order to support fidelity to our primary outcomes. And this current analysis really leverages these first 2 data sources, which I'll now speak to in more depth. Knowing that a picture can be worth 1,000 words, I'm going to aim to show you how we use implementation science data to inform where to implement INTEGRA. So through our pre-implementation landscape analysis, we first documented the geographic boundaries of local neighborhoods with both high HIV incidence and overdose rates at baseline. And so we mapped those geographic boundaries And then to characterize proximity to MOUD, HIV, and primary care services in those neighborhoods, we added green geotags to the map. And then to characterize proximity to institutions that may discharge people who inject drugs back into the community, we added red geotags for things like hospitals, urgent care, jails, and prisons. Then in the implementation phase, we used weekly ecological assessments from each site to document and date the crossroads where the INTEGRA was actually being delivered. And for each unique crossroad, we added a band geotag marker. We use this data to compute driving distance and to triangulate locations where people who inject drugs were enrolled, and in which neighborhoods might reflect high enrollment neighborhoods. We defined high enrollment neighborhoods as those where more than 30% of the participants from each site were enrolled, right? Meaning that we had good reach in those neighborhoods. And then we characterized through open-ended prompts neighborhood factors that affected their ability to reach people who inject drugs and to provide integrated care in the mobile unit. New implementation neighborhoods were added to the implementation maps as needed, and those are observed through these blue geographic boundaries. And qualitative responses were grouped by implementation neighborhood and then thematically coded quarterly and iteratively discussed by the implementation science team. And the coding really aimed to describe the observed social, physical, drug use, and socio-political environmental contexts that were affecting a given neighborhood's viability. So first, let's just review some of the characteristics of the neighborhoods initially selected for implementation. First, you'll see that HIV and overdose epi data identified about 3 to 4 priority neighborhoods in most sites and 10 neighborhoods in Houston. The overdose deaths were highest across the Philadelphia neighborhoods compared to all the other sites, where Houston and LA had a broader range of overdose deaths across their neighborhoods. Similarly, the highest HIV incidence, while it was observed in the downtown LA area neighborhood, but LA and Houston continue to maintain kind of a broader range of HIV incidents across their neighborhoods. Houston had subsequently lower access to services within priority neighborhoods, and you'll see that very clearly on the maps here in a minute. But comparatively, the priority neighborhoods in New York and Philly and in some areas of LA had much greater access to services, with the highest number of services being documented in Philadelphia's Kensington neighborhood. And kind of through probative observations with our IS team, we figured out that the higher number of services in Philadelphia neighborhoods was really due to the fact that there was a standing order for all pharmacies to provide naloxone. So that substantially increased access to harm reduction services across the city. So anywhere there was a CVS or a Walgreens, there was a geotag because that is where harm reduction services could be accessed, right? So the density of services was much greater there. And then the number of sites where people who inject drugs may re-enter the community was greatest in New York City's East Harlem neighborhood. So the geographic distance across priority neighborhoods, and so how far it took to travel to be able to implement the intervention each day, and the density of MOUD, HIV, and primary care services are going to be depicted on the pre-implementation maps on the left. And here, when we look at New York City, we see 3 of the 4 New York City neighborhoods are really within close proximity to each other, right? So that's where the epi data said go to. They were really in close proximity to each other with relatively robust access to services in their geographic boundaries. And the same is true for Philly, right? What you're seeing here is that like the neighborhoods are in relatively close proximity to each other, and there's just this density of service access in those neighborhoods. Where in contrast, what you're seeing for DC, it's characterized by access to fewer services. So that density of services is just, it starts to become a bit more sparse. And comparatively, Houston's across their 10 neighborhoods, it's quite striking when you look at it compared to the previous maps. So even despite having greater geographic distance and coverage, the service access is still very, very sparse in comparison. Similarly, LA's neighborhoods are much more dispersed, so there's a lot more geographic distance in between those priority neighborhoods, though there are some pockets within specific neighborhoods where there is greater access to services. Whoop, is that where we were? Okay, thought I jumped ahead too much. So the first two columns here on this table, you're going to look at the number of priority neighborhoods we identified in pre-implementation phase, right next to the total number of neighborhoods where the intervention ended up being delivered. And of the 24 priority neighborhoods identified in the pre-implementation phase landscape analysis, 18 were initiated in the implementation phase, as were 17 new neighborhoods not previously identified through our landscape analysis and EPI data. 6 priority neighborhoods were never initiated, including 3 in New York and Philly, and that's because they had very high enrollment neighborhoods and they didn't need to move into other priority neighborhoods they had previously identified. And then there were 3 in Houston that were never initiated, mostly because there was limited mobile unit parking options. So like, they didn't really have any parking space where they could set up in the first ward, for example, or because these other viable neighborhoods emerged through local response systems that they didn't capture in their EPI data. And we'll talk about that a lot more here in a minute. Another thing to note is the driving distance is quite different as you go across sites. Driving distance one way from where the mobile unit is parked to the implementation sites within a specific neighborhood on average reflects much greater geographic distance across neighborhoods for both Houston and LA. And overall, the 358 participants who were enrolled as of April 2023, when we ended data collection for this particular analysis, there were much fewer participants enrolled in DC. And enrollment continued through the end of September of that year, but the proportion of where people who inject drugs were enrolled and the characteristics of the implementation neighborhoods did not change in that 5-month time span. And then all sites, except for Houston, had at least one high enrollment neighborhood, where at least 30% of the participants from that site were enrolled. So now moving into our implementation neighborhoods. As I mentioned previously, the new implementation neighborhood boundaries that were new were added to Google Maps in blue, and a purple van marker was placed at each cross street where the mobile van delivered services. So if that mobile van parked at that same cross street 5 days in a row, it only had one geotag, but if it, moved a block up or a block over, it had a new geotag for that neighborhood, right? And then a magenta geotag marker indicates that the cross streets were in a high enrollment neighborhood. So the implementation sites are very densely concentrated. When we go into New York, the implementation sites are very densely concentrated within the neighborhoods, and 58% of their participants were enrolled in the East Harlem neighborhood. You see similar implementation sites were even more densely concentrated in Philly, and 89% of their participants were enrolled in the Kensington neighborhood. Implementation sites were, again, more dispersed across DC's 6 neighborhoods. So they ended up onboarding several new neighborhoods, and you just see how, compared to the other sites, the van really needed to spread out in order to try and find and reach people there. And that is with the exception of Ward 5, which is right in the kind of like the center of that little crook of their map, where you see a very dense placement of magenta geotags. And that is where in Ward 5, where 38% of their participants ended up being enrolled. And then the implementation sites are the most dispersed in Houston. They ended up having 16 enrollment neighborhoods, which partially accounts for why there was no single site with a high enrollment neighborhood, right? And in contrast, in LA, the sites were much more concentrated than Houston, with the exception of downtown LA, where you see a bit more spread, kind of a bit more similar to what you saw in DC. Downtown LA ended up being where 31% of the participants were enrolled in the Los Angeles site, but the van still had a fair bit of movement within that neighborhood. And we'll get to why that is in a minute. Because a lot of those factors, that speak to why some sites are much more dense than others, more geographic spread than others, really came through when we talked about the contextual barriers and facilitators that characterize the viability of implementation neighborhoods, and the benefit of utilizing these new and additional systems of information to guide real-time implementation decisions beyond the pre-implementation surveillance data. So where we could get a little more squeeze. Moving back into New York, across New York's implementation sites, where they were much more densely concentrated, specifically in the East Harlem neighborhood, and even in the other 3 sites, where the reason for this concentration really was the presence of an open drug market. And in fact, they were in the East Harlem site for a full year, and probably would have stayed in the East Harlem site for the rest of the study, except for that after about a year, a police command station was set up right at the intersection of this major metro subway stop, and people were coming in through that metro stop and then walking to Marcus Garvey Park, getting what they needed, using what they needed, and then kind of dispersing throughout their day. But this presence of this police command station, and we're talking about they had the full command doing their roll call in the morning there publicly on the streets, was just massive. And it really disrupted this and dispersed this open drug market, so that they couldn't really reach people anymore, and they had to go find other places in different neighborhoods where they could reach people to be able to deliver integrated care. And the density of the implementation sites, where you kind of see like the van is markers are kind of just really closely stacked on each other, could often be within blocks of each other, right? Where they just needed to move the van 1 or 2 blocks in order to bridge these drug turf barriers that meant that people, couldn't cross the street or cross that intersection in order to access the van, even if they could see it, right? So they had to move the mobile van across the street so people could reach it. And we see a bit of that experience reflected in this quote, where the site staff said, we identified a few fresh places to move, keep things fresh. One is called Little Jungle, an encampment where folks sleep at night and use 2 blocks from where the van is parked. Some folks just don't make it that far. So bringing the truck over to this side of the street. And so when we were reading these responses, I was like, well, why? What is the reason why you got to move the van, right? And that's how we understood that there were these drug turf barriers that were really preventing people from being able to cross the street and leading to their ability to reach people. But there's the ability to reach people were still in the very clustered, because there were other similar open drug markets, related to these encampments. They were well known, such as the hub or the underpass, that facilitated concentrated enrollment in neighborhoods. And they just needed to park up by the underpass and they'd be able to reach people and deliver care quite easily. Very, very similar observations seen in Philly, where the sites were highly concentrated. And similarly, that's because it was characterized by the presence of an open drug market. In the Kensington neighborhood, where 89% of the participants were enrolled, it was the sole recruitment neighborhood, essentially, for the entire duration of the study. All but 2 weeks out of the 410 days they were in the field, they were in the Kensington neighborhood. And I know it looks like there are only 2 van geotags there, and that's because they traveled less than the span of 1 mile in that neighborhood in order to enroll 89% of the participants, right? So Kensington's characterized as the location where everyone travels to procure opioids. And when they started going into Philly, this is one of the observations that was reported back, starting to move more to West Philly, most folks are not injectors, are not injecting opioids. West Philly, people who inject drugs are going into Kensington anyway, from home to buy drugs, to use, and to use services such as the sterile syringe programs there. So Kensington is still the most high enrollment neighborhood. And in fact, when they talked with folks in the West Philly site, they said, "Man, I'm seeing you in Kensington. I'd rather see you there, like not here." And so they ended up just staying in Kensington the rest of the duration of the study. Comparatively across DC, where sites were less implementation sites were less densely concentrated, and where they had much lower enrollment numbers than anticipated. All of this reflected challenges in being able to reach people who inject drugs in the usual neighborhood. This team had a lot of experience working with previous studies, enrolling people who inject drugs, and this study was implemented in the midst of this rapid gentrification process that was happening, where these huge, apartment buildings and condo buildings were being converted. And it was paired with this overt police surveillance that was happening at the same time in this neighborhoods, really just kind of dispersing everybody underground or just outside of those neighborhoods. They weren't really able to reach them, even though that's where the data had said to go. They also observed shifts that were happening during the enrollment period, where younger people who use opiates were shifting away from injecting or just not initiation injection, largely due to fentanyl in the drug supply. So what we observed, we're able to observe through the qualitative data, these ecological observations, is that DC was in this transition away from a more open drug market. And the neighborhoods where there were more visible drug markets, the staffs often deemed them kind of too unsafe to park the mobile unit for prolonged periods of time, because it's a big unit. You have to get there, you have to get things set up, get it ready for care, get it leveled, and you get the generator running, and you can't really just kind of like pick up and move that quickly if there are some shots that you hear fired down the street, right? And so they ended up getting a second mobile unit, something that was more like a Sprinter van. And they said having the second mobile unit that is smaller is very helpful for field safety and security. The smaller unit, not used to implement integrated care, is making it easier to kind of more quickly get in and out of these places, scope them out, do outreach, connect with people, and tell them where to come meet up with us at the mobile unit. And that's the reason where we end up seeing Ward 5 becoming the high enrollment neighborhood, because when they were out talking to people, engaging with people through the Sprinter van, through outreach, the place where people felt safe going to and meeting them at the van was in Ward 5 at this Metro Transit hub outside of Heshinger Mall, right? And so that's the reason why they ended up having a high enrollment neighborhood, kind of densely concentrated in that little nook there. Another observation was that there was they continued to follow the overdose data that were being reported, but the overdose data was tied to increased policing, and it really wasn't helpful in finding people. So the site reported, for example, doing a lot of community work with the Department of Behavioral Health and community-based organizations. We're now part of the rapid response team. They get called up to go to respond to overdose spikes, but it's become public news that by the 7-Eleven or by wherever the overdoses are happening, police are putting up remote devices and surveilling the area where there are overdoses. So rather than being able to reach people with those services in an area where there's been increased overdose, people are again being driven further underground and dispersing and further away from where they would be able to reach these harm reduction and integrated care services. So similarly, when we move into LA, again, the implementation sites you see are kind of less densely connected to each other. There's a lot more geographic space in between the neighborhoods, compared to like New York and Philly. But they also were not characterized as having open drug markets. And so further, the drug use in downtown LA was maybe more visible than the other sites. Some area of Long Beach, there was a bit more visible drug use. Still nothing compared to what was observed in Philly and New York, but like what was visible varied by the types of drugs that were being used and the route of administration. And you really have to get into that neighborhood, start talking with people, start hanging out, parking outside of the liquor store to kind of start to observe that like what's really happening on this block, for example, is people are more using alcohol and meth. and there's not really any injection drug use or opioid use. And so you start talking to people and they're like, go 2 blocks up and over, and that's where you'll find the people that you're looking for. And then they ended up moving out of Long Beach into downtown LA because there was a high concentration of homeless encampments, and the overdose data took them there. So again, the sites continued to follow the overdose data to see if there were new enrollment neighborhoods where they needed to be. And this is their reflection on the overdose data in LA. Overdose data and HIV maps took us to Long Beach, but the data are really not granular. So it was hard to locate where to actually park the van. So our strategy was to ask the gatekeepers, and the gatekeepers in those locations kind of really didn't know. They didn't know the difference between what types of drugs and how people were using them. They just knew drugs are being used here, drugs are being used there, which is why they ended up popping around the Long Beach neighborhood and hunt for people, right? But then when they first went into downtown LA, they said, we followed the overdose data to MacArthur Park. It wasn't useful. There were overdose deaths, yes, but they were not our people, meaning that the people who were being affected by overdose were not people who were injecting drugs, right? Or had no drug, so they wouldn't be eligible for this particular study. However, when they were downtown, they got connected to this thing called Project Room Key, which popped up during COVID. And that's where Project Room Key was where they started housing people who were unhoused in the downtown hotels during COVID. And so, they would be parked outside the LA Grand, for example, and then they would move to another big hotel. And the Project Room Key staff and the hotel staff, all were really excited to be able to have INTEGRA show up and provide care and provide services. And so they were able to reach people. And that's why you see those vans are kind of more dispersed, because where they are is around where those different Project Room Key hotels were. And the density of the implementation sites in all of the LA's recruitment neighborhoods were very uniquely tied to different housing situations, such as sober living and transitional housing in Long Beach. So where you see those vans being clustered is where they started to find those sober living and transitional housing areas, the hotels in downtown LA, and then everywhere kind of around that, especially including those new neighborhoods that are added, where you see these little pop-up bubbles of implementation sites that are very close together. That's where the tiny home villages were being set up. So again, in response to the housing crisis in LA and during COVID, they started building these tiny home villages. They weren't big. Maybe one village housed 40 people, but about 10% of the people would be eligible. So if there were 40 people at one village, they were able to reach 4 people and provide, access to care. If there were 100 people in another village, they were able to reach 10 people and provide access to care. And so they were able to just go to those villages and reach people because of their connection to housing. In particular, the implementation sites in Long Beach, you see that huge geographic difference, but distance between them and the other neighborhoods is really what ended up accounting for the higher average driving distances in LA compared to Houston. So there was always a conversation about who's driving more, who's spending more time on the road. And the LA site reflected on this in one of their observations, saying the LA geography, everything is out of the way. Nothing is close. Makes it challenging to get places because in between the distance is traffic, right? So it took quite a long time to be able to get places. And then in contrast, moving into Houston, you see that the implementation sites are very spread out. And in some of them, it looks like they're lining up almost. And that's because where they were parking a lot of the times was in relation to the inner and outer beltway and the spokes of that freeway, those freeway entrances and exits, right? And similar to LA, while neighborhoods might be known for having high levels of drug use, the types of drugs that were being used and the routes of administration really varied more neighborhood to neighborhood in Houston, whereas in LA it kind of varied more block to block, right? So you had to kind of get up and move around blocks, whereas in Houston it was kind of like, this is not the neighborhood, we need to try another neighborhood, right? And so what ended up happening is that, the vans were more dispersed. We ended up having multiple low yield neighborhoods. And that was really just because the types of drugs and how they were being used in those neighborhoods just, weren't related to opioids or injection drug use. For example, a community member stated that most of the drugs used in this area is non-injection crack and recommended mobile units move further east. Stated main problem in the Sunnyside area is poverty. So social services, housing, jobs, ID, crime prevention are all needed more than help for opioid use. And like DC, Houston's implementation neighborhoods with greater enrollment, even though they didn't have a high enrollment neighborhood, was really linked to these transit hubs. So, being in close proximity to a metro light rail or to trusted venues with high foot traffic in the neighborhood, such as gas stations. And a lot of times those gas stations were also, similarly, the places where people may be going to and from to also get drugs, but they were a great place to also co-locate the van and to be able to reach people. And unique to Houston, they formed a relationship with Houston's fire department's overdose response team and used their reports to help identify new neighborhoods. And so their expansion of new neighborhoods grew much more rapidly once they built this relationship. And for example, the Houston Fire Department has an outreach worker that follows up with individuals that received care for overdose. Our peer navigation supervisor rides along with the outreach worker and shares neighborhood information with the HPTN 094 team when there's clusters of overdoses. And so unlike DC, right, where the overdose ongoing data was not helpful because it was tied to police surveillance, this was very helpful. And it helped them to even understand where in a neighborhood they are to move the van to be closer. So like we're currently parked by the auto zone over here, but really we need to go on the other side of this parking lot to this side where there are the hotels, because that's where they've been responding to a cluster of overdoses. And sure enough, we're finding people, right? And so that relationship with the Houston Fire Department was very, very helpful. Kind of across this, our findings really just kind of highlight the important connections between the outer community environment, that environmental context where people are, on the implementation of complex interventions in local neighborhoods. Specifically, neighborhood level data on drug use and geographic diversity, alongside these kind of shifting socio-political factors such as policing, surveillance, gentrification, really differentially affected the utility of EPI data in identifying viable implementation neighborhoods across sites. Where there were open drug markets, EPI data worked just fine. Where there were not, it was much, much less useful, right? In sites where people who inject drugs are more geographically dispersed, the proximity to structural factors, such as public transportation and spaces where people who inject drugs reside, played a role in determining more suitable implementation sites. And the utility of leveraging additional data from local overdose and housing response systems to identify viable implementation neighborhoods was mixed. It worked very well in LA, tied to new housing sources. It worked very well in Houston, tied to the fire department's overdose response team. It was completely counter to the mission of everything in DC when it was tied to express surveillance people. Of course, this study, as with all, are not without limitations, and chief among them is that the assessment periods of neighborhood viability was not standardized. This was a pragmatic trial in that sense, right? If the team got in and was like, this isn't working, or the people we're talking with tell us, Sunnyside's not where you need to be, we left. We didn't hold them to stay in that neighborhood for a specific amount of time so that we could standardize the observation periods. Causality cannot be inferred from this study, even though we prospectively, looked at these things over time. The mobile unit may have also had affected some minor socio-political shifts. We didn't really get any reports back of that, but it isn't something that we can rule out either. However, the triangulation of the observations across sites and data sources really does help to strengthen the external validity of our findings. And finally, our findings contribute to the literature and suggest that data-driven approaches may provide a pragmatic strategy to guide real-time implementation of integrated care models in local communities with heterogeneous geographic and drug use landscapes, heterogeneous sociopolitical landscapes, right? And that these real-time implementation evaluations might help us to better meet the needs of out-of-treatment people who inject drugs. We demonstrated our ability that integrated care delivered in mobile units can expand service reach to underserved communities. Few studies have described how or even if a process was used to optimize the reach and adoption of mobilized services. So that's very much a novel contribution of this work. And importantly, we attended to this external environmental context that expands beyond traditional surveillance data as a pragmatic strategy to guide real-time implementation of complex interventions in underserved communities. And it provides a framework for expanding pragmatic data-driven approaches to expand the implementation of integrated care models for people who inject drugs, as well as similarly criminalized and minoritized people and communities across diverse landscapes in the U.S. And so with that, I want to thank the HIV Prevention Trials Network and our funders, the National Institutes of Health, as well as all of the HPTN centers that supported this trial, and many, many, many people involved along the way. And also to note that the content is the sole responsibility of the authors and does not necessarily reflect the official views of NIH, especially now, I'm sure. And then just to show, happy to send out the slide deck, or they'll be on the video, our different citations of the work that our colleagues have done that help to inform this study and contextualize our findings. And with that, I'll end with a big thank you to you all, and I'm looking forward to some conversation as soon as I can find the stop share button.
Thank you, Laramie. That was a beautiful presentation. I love the maps and the qualitative quotes, and it was great. I see a question from Tom Martin down in the chat asking, has wastewater data been used to guide interventions like INTEGRA?
That is a great question, and I do not know. It could be. I mean, it's something that could certainly be used to guide. I guess it can help you understand what drugs might be coming through in different neighborhoods, but may not inform whether or not the route of administration is injection drug use. And pragmatically, the public health implementation of something like INTEGRA probably should not restrict inclusion criteria to whether or not you are injecting, but for the RCT, that restriction was in place. So, and we really did see in the route of administration was very different in LA and Houston across sites. Yeah.
I see Natasha has her video on. Do you have a question, Natasha?
If others don't want to jump in. Laramie, that was a beautiful talk. Thank you so much. Such a fascinating study. What a great piece of work. I guess I had a question. Your team has obviously done such an incredible job of mapping these areas out, working with local, partners where they can to sort of guide this in real time. Do you have a sense, and I'm sure this varies city to city, of course, but I'm just thinking about implementation in other settings that might not have the resource and the time to be able to do this sort of on a consistent basis. Do you have a general sense across your sites, once you have a map, once you've gone in and done your best to kind of map it all out and understand the basics, how much does this change? You're talking about being guided by overdoses and even one block and where people are being housed. Again, I'm sure it varies city to city. But once you have a map, could you feasibly think about maybe only updating it once a year? Or is this something that you got a feeling that this is really changing quarter to quarter?
Yeah, that is, oh my God, I love that question so much because my answer is obviously, well, it depends. It depends on how much is happening in the city, right? So like, for example, in New York, they had their their neighborhoods kind of mapped based on like where there's a more open drug markets, I think that you can do it much less, right? Because unless there's some major kind of shift, such as setting up the police command station or rapid and persistent sweeps in a particular neighborhood, those kinds of things, it isn't changing much, right? And so you probably don't need to do it as much. But then, and granted, this study was implemented during COVID where so much was changing rapidly, right? But for example, it like once LA got in contact with that housing system, they could have just kind of kept updating the maps based on the new tiny home villages that were popping up, right? And really it was that more than anything that was driving the movement and the ability to reach new people, right? They didn't go into Skid Row because it was saturated, quite frankly, right? And so they didn't even go into Skid Row in LA. But they like so I think that one could have just kind of, you got tapped into a new system that is helpful, keep following that. But for Houston, for example, it kept changing, and it really was that connection to the Houston Fire Department that kept them going, and they were all over the place because of that, and they probably reached a lot more people that they wouldn't have reached had they not had that connection and they had not been constantly updating it with that source of information. So I really think that it depends on kind of the city, right? But I think for the example in particular with Houston and LA, they had tapped into that source and made that connection. So, to the extent that they would need to keep mapping, probably not, right? Because if it's just a public health service being implemented, then they're connected to a source that's helpful, and then would probably come back to it if, they stopped reaching people.
Such interesting implications for sort of data, the need for frequency of data availability and sustainability with these different programs in the different settings. It's great. Thanks, Laramie.
Of course.
Abuse of my privileges as a moderator, and then I'll ask Dr. Blanchard to ask her question. But just following up on that, is the plan to create some sort of blueprint based on kind of city typology in terms of density of services, distances, that approximates the best strategy to implement the mobile clinics? Is that even possible, or the answer given all these variation is no?
I think that the answer given all the variation is we have good suggestions and guidelines for different sites to trial, because they might have, there could be similarities based on what their drug markets look like. There could be differences in, say, whether or not they have a good transit system or not, right? So we were in a city that didn't have a good transit system, So that may be that would be something, getting into a city like that where we might need something newer to kind of help inform. But that was kind of a unifier for those, especially that didn't have a kind of an open air drug market or concentrated drug market. But yeah, it's a great question.
Thank you, Laramie. And Dr. Blanchard, please go ahead.
Hi, Gigi Blanchard. Laramie, thanks. That was an awesome talk. This is kind of a more random question, and forgive me being in the car, but I was listening to a rebuttal of some Trump statements, and they were talking about how rates of drug overdoses have actually gone down over the years. And I'm wondering, based on your experience now, do you think that that's truly accurate, and where rates are going down with projects like yours and other programs being implemented? Or do you think it's, as you described with the police headquarters, it's being driven underground and we don't really know what it's supposed to be?
Yeah, that is a really great question, and there may be some folks on this call who can speak to this from other data with a little bit better than I can, but from the data and the research that I've been following, I think that the rates are going down, but it's a mixture of things that have been happening. It's that public health responses and grassroots organizations have done a lot to help increase awareness about overdose prevention, flooding areas and neighborhoods and communities with access to naloxone that is saving people's lives. And then also there has been some shift in the potency of fentanyl, and kind of the way that it's being distributed, or people are using it too, and so that's kind of shifted and reduced some of the fatal overdose, so I think that what they're seeing in terms of those reductions are real numbers from what I understand. Certainly, but to your question, I'm sure that a lot of that is because it's been more of a public health practice driven and structural, response driven versus policing and surveillance driven. I don't think that anywhere we would see policing and surveillance driving reductions in overdose.
And so do you think that impacted your study?
It certainly did in DC. Yeah. I mean, and we saw the impact in the Harlem neighborhood, but the Harlem, the site that where they were set up was set up for, political reasons. It was set up to be visible on purpose. And it had its effect, but they didn't then spread that everywhere else out. The rest of the encampments were kind of left alone, right? And so, but it affected DC very deeply. People just weren't they were hiding. They didn't want anything to do with what was happening. And it was like banks of cops. It's like, we're building this apartment here and it's basically got cop cars just lined up on it. And the places where people would normally hang out in front of the McDonald's, they just put cop cars lined up in front of it. They were like, do not be here. This is no longer your neighborhood. It was very clear what they were doing.
Thank you.
Yeah.
Still have 1 minute. I'm going to ask one more question. Do you think, the fact that INTEGRA got together with, the paramedics from the fire department with the housing services, is that, it's even more integration of services in a way than was originally planned? Do you think there's going to be an INTEGRA 2.0 that actually works to formally, create this service integration with social services? Or is this enough to kind of prove the utility of service integration more broadly outside of health?
Yeah, well, I have two responses to that. One is, I hope so. Well, the first response is the outcomes of INTEGRA and whether or not it was effective on its individual outcomes. We don't know yet. We're still blinded to those results. They're not out. So I can't speak to that. But what I can speak to is I would hope so. I would hope that we could show a deeper, more meaningful impact by partnering with other structural, response systems, and broadening the spectrum of integrated care. In particular, we don't have, outcome data that speak to this, but from our ecological observations, something that was missing in our integrated care model was mental health services, right? And so that's another thing that could be, better integrated, I think, in future iterations. Whether that will happen, I don't know, because I don't know what's going to happen to the network and funding in general for anything right now. But I do hope that these data can help, whether it's through research or through public health practice, speak to the need for that bridging and that partnership building, and deepening impact.
Thank you, Laramie. This was brilliant. Really nice ways to close the week. Have a nice Friday and weekend, everyone. And see you next Friday. Bye.
Thank you.
Thank you.